employer, and I'm subcontracted to support the State Office of Rural Health team, David Conrad and Abby Garcia, in providing technical assistance and education for the Medicare Beneficiary Quality Improvement Project. And we are very excited to have with us today Dr. Arjun Srinivasan. He is going to be discussing implementing antibiotic stewardship in rural and critical access hospitals. All lines will be placed on mute to cut down on background noise and improve the quality of our presentation today. So I'd like to thank Ali Orwig with IRHA for providing the technical support for today's program. As all of our programs, please feel free to unmute your line or contact Ali to unmute you or chat your question. I'll also be providing my email address if you prefer to email me questions to ask Dr. Srinivasan today. The presentation was sent out Tuesday evening. There were a couple of updates to a couple of the slides that had been previously shared. That's around 7:34 in the evening on Tuesday that was distributed, if you'd like to pull it up to follow along today. And at this time, I'd like to introduce Dr. Srinivasan. We're very excited to have him with us today. Dr. Srinivasan is the Associate Director for Healthcare-Associated Infection Prevention Programs at the CDC. He has expertise in antibiotic use, antibiotic resistance, healthcare-associated infections, and healthcare-related outbreaks. He really envisions a future where patients are safer because healthcare-associated infections have been stamped out and antibiotics are used correctly. He's very dedicated to this passion. He directs the CDC programs aimed at preventing healthcare-associated infections and advocates for everyone from patients to farmers and agriculture to physicians to get smart and understand when antibiotics work and when they don't. So at this time, I'll turn it over to Arjun for our presentation today.
Thank you so much. Hi, everyone. And thank you, Becky, for giving me this opportunity to talk a little bit about implementing stewardship in rural and critical access hospitals. And this has definitely become quite a passion of mine after really hearing and learning from so many folks in the critical access hospitals and in these smaller hospitals about their frustrations with trying to implement stewardship programs, but really struggling because there were not specific ideas and thoughts about how to do it that were in tune with their settings. And so we've done a lot of work in this area to try and support the work that you all are doing, and do hope that you will let us know what more we can do to help you in your efforts to improve antibiotic use. You know, I think this is important to emphasize that antibiotics are completely different from all other drugs. So we often talk about, using medications wisely, and that's really important. We want to use every medication wisely, but antibiotics are a little bit different from every other drug, and they're different for a couple of reasons. One is because antibiotics are the only drugs that we have that by definition lose their effectiveness over time, even if we use them perfectly, right? So an antihypertensive drug, so hydrochlorothiazide, invented 50 years ago, works every bit as well in an individual patient as it did the day it came on the market. Penicillin, absolutely not true for that drug. Antibiotics are the only drug that are used so broadly. Pretty much every specialty prescribes antibiotics on a regular basis. There's no other drugs that are so commonly and widely prescribed. And most importantly, they are a shared resource. So they are the only drug where how we use them in one patient can compromise how they work in someone else. For example, if I use antibiotics badly in your hospital or in a clinic that sends patients to your hospital, and I breed resistant bacteria or create Clostridium difficile in my patients can come to your hospital and spread those infections to other patients. And so you will suffer the adverse consequences of my poor antibiotic use, even though I've never seen any of your patients. And as we've seen from these dramatic examples, this can happen across town, across the state, or even across the globe. And so these are the reasons why we focus on efforts to improve antibiotic use, distinct from our efforts to try and use all medications well. We know that even when we use them well, antibiotics can be dangerous drugs. There are certainly adverse consequences from being exposed to any antibiotic. We know that there's a selective pressure for antibiotic resistance. If you get put on an antibiotic, your risk of having a resistant bacteria goes up many-fold. There's an increased risk of getting a fungal bloodstream infection, candidemia, if you get an antibiotic. One of the most well-established risks from being exposed to antibiotics is, of course, Clostridium difficile diarrhea, where there's an increase from anywhere from 7 to 10-fold, and that increase lasts for months after you get the drug. There are adverse drug reactions, problems with the renal function, nephrotoxicity, bone marrow suppression, all sorts of these adverse drug reactions. And we know that when we give people antibiotics, it disrupts the normal bacteria that are in their guts. And we're increasingly understanding that this disruption of your normal bacteria, the microbiome, can predispose you to a lot of potential adverse events, including an increased risk of sepsis. And so we know that these are all consequences of being exposed to antibiotics, whether you need them or not. The issue is that if you need an antibiotic, these are all acceptable risks. We will take these risks because the benefit of giving you the antibiotic outweighs these risks. But when we give someone an antibiotic that they definitely don't need, then we are exposing them to all of these potential risks with no benefit. Antibiotic resistance is not only a problem in and of itself, but it fundamentally threatens the way that we deliver modern medical care. Antibiotic resistance literally cuts across all sectors of healthcare delivery. It's a threat in inpatients, in outpatients, in nursing homes. It is a threat in the community. It is a threat in healthcare. It is a threat in agriculture. It really is an equal opportunity killer. The issue is also that antibiotic resistance makes it much more difficult to practice medicine. If you can't prescribe antibiotics safely, it becomes very dangerous to do chemotherapy, for example. It becomes much more dangerous to do surgery, right? So there were all these medical advances that we are able to do, all these advanced procedures, and we can do them because we have antibiotics to bail us out if a patient gets an infection. And we know that infections are common risks of having surgery, of getting chemotherapy. If we can't give people effective antibiotics, it becomes much more dangerous to do these types of modern medical procedures that many of us are luckily able to take for granted today. This is some data on the risks of sepsis after getting an antibiotic. You know, we're certainly focused on the challenge posed by sepsis and the mortality from sepsis. And what we're understanding is that if you get an antibiotic, you actually are put at an increased risk for potentially getting sepsis. This shows that patients who were discharged from a hospital and got a broad spectrum antibiotic during their hospital stay were up to 50% more likely to be readmitted to the hospital with sepsis down the road in the next 90 days. And again, we think that's because the antibiotics that you're getting disrupt your normal gut bacteria, your microbiome, which then increases your risk of sepsis. And we like to tell people that this is a matter of patient safety, right? So we don't have to think about theoretical patients down the future and talk about improving antibiotic use because we are saving them, quote unquote, for some future patient. It's really not the case. What we're really focused on are the patients in the beds in front of us. We are trying to protect them from getting adverse events that we could prevent by preventing unnecessary antibiotic exposures. And this is just a couple of numbers to help frame those risks, because I think it's really important for us as providers to be armed with this information so we can help understand what these risks really are. So in the outpatient setting, sometimes patients will say, well, you know, I have a cold and maybe I don't need an antibiotic, but I think I should get one because it might prevent me from getting a pneumonia or from getting an infection down the road. And it is true that a small number of patients who get a viral respiratory tract infection will subsequently develop a pneumonia. How often does that happen? Well, the literature shows that that happens about one time in every 4,400 patients. So you would have to treat over 4,000 patients to prevent that one bacterial pneumonia. But how many patients do you need to treat in order to harm someone with antibiotics? Well, we know that for every 1,000 antibiotic prescriptions, one patient will develop an adverse drug reaction that's serious enough to land them in an emergency department. So when we're encountering this situation, it's important to help people understand, your patients understand, you know, I am 4 times more likely to send you to the emergency department with an adverse drug event than I am to do you any benefit from giving you this antibiotic to treat a viral respiratory tract infection that doesn't need an antibiotic. On the inpatient side, we know that adverse drug reactions are even more common. About 20% of patients who are exposed to an antibiotic in a hospital get one or more adverse drug reactions, including things like Clostridium difficile infections or drug-resistant infections. And that 20% holds true whether the person was getting an antibiotic that they needed or one that they didn't need. And every 10 days that you get an antibiotic in a hospital is associated with a 3% increased risk of one or more types of adverse drug reactions. And these are not trivial events. 97% of these adverse drug reactions resulted in either additional testing or some sort of additional medical care, including a prolonged hospitalization, a new hospitalization, or a visit to a clinic or an emergency department. We know that antibiotics are used very commonly in acute care hospitals. This is data from a paper that we published a few years ago, and it showed that about half of all patients who get admitted to a hospital get exposed to an antibiotic, and this has been confirmed in multiple different studies, this 50% number. And our rate of antibiotic use is very high in acute care hospitals. It's about 755 days of therapy for 1,000 patient days. So if you think about this another way, about 75% of all hospital days involve at least one antibiotic. It's important to note that this use does not vary by bed size. So small hospitals and large hospitals have roughly equal rates of antibiotic use. And it doesn't vary based on teaching status. You know, there's this bias that antibiotic use is higher in larger and in teaching hospitals, and that's not true. Antibiotic use, what we use in hospitals, is changing over time, and unfortunately, it's changing in a fairly concerning direction. What we're finding is that the broad spectrum antibiotics, things like beta-lactam and beta-lactamase inhibitors like piperacillin tazobactams and carbapenems, are being used with increasing frequency over time, which I think reflects both the reality and the fear of increasing antibiotic resistance. That would all be completely fine if all of that use was necessary, but we know that about 1/3 of all the antibiotic use that occurs in hospitals is not needed. And this is a very nice study where they looked at the reasons why antibiotics are prescribed inappropriately in hospital settings, and most of the unnecessary use falls into one of these 3 buckets. We give antibiotics for longer than they're needed. We give them for patients who have non-infectious or non-bacterial syndromes, or we give them to treat colonization or contamination rather than actual infections. I alluded to this earlier, but what we have found is that rates of antibiotic use do not differ significantly based on bed sizes. And so this is data that's been reported to CDC, and you can see that hospitals less than 25 beds, 26 to 50 beds, and greater than 50 beds all have about the same rates of antibiotic use. And so smaller hospitals and critical access hospitals are using antibiotics as frequently as their larger hospitals. We also know that critical access hospitals are definitely not spared the problems of antibiotic resistance and Clostridium difficile. I'm sure that all of you have had to treat patients with methicillin-resistant Staph aureus, with Clostridium difficile in your smaller or critical access hospitals. And many of you, I would bet, are now encountering these infections caused by these highly resistant gram-negative pathogens. For example, we have data in CDC showing that this seems to be increasing over time. In 2015, fewer than 2% of critical access hospitals reported an infection with one of these highly resistant gram-negative pathogens, things like carbapenem-resistant Enterobacteriaceae. But in 2016, that had increased to almost 3%. So we are seeing some concerning trends of these highly resistant gram-negative pathogens being encountered more frequently in critical access settings. So it's important to note that if we are able to improve the way we use antibiotics, we can achieve important benefits in these bad outcomes. So let me show you a couple of examples, and this is one looking at antibiotic resistance. And so this is a study where they randomized patients to either get short courses of antibiotics, shown here as the ciprofloxacin arm, or a standard course of antibiotics. So in the ciprofloxacin arm, patients who had suspected pneumonia got 3 days of therapy, and then if they didn't have pneumonia, that therapy was stopped at 3 days. Other patients were randomized to get whatever the provider would have normally prescribed. And on average, those patients got about 10 days of antibiotics. And you can see if you got the shorter course of antibiotics, you were had a much shorter length of stay in the ICU. You were much more likely to be discharged early from the ICU. And more importantly, you were significantly less likely, less than half as likely, to develop an antibiotic-resistant superinfection during your hospital stay. So shortening the duration of antibiotics protected this group of patients from getting a resistant infection during their hospitalization. We also have really good data showing us that if we can reduce unnecessary antibiotic use, we can have a major impact on Clostridium difficile. And this has been demonstrated in individual hospitals, but the data that I'm showing here is actually even more impressive because it's data for an entire country. So England has undertaken a major effort to reduce unnecessary prescribing of cephalosporins and fluoroquinolones, especially in adults over the age of 65. And as you can see, as they have been able to reduce this unnecessary antibiotic use, they have seen a dramatic reduction in Clostridium difficile, a more than 70% reduction in C. difficile over this 7-year period. So really dramatic impact on C. diff that we can have if we improve antibiotic use. And finally, we know from good randomized studies that if we have antibiotic stewardship programs, as we are encouraging all hospitals, including critical access hospitals, to do, we can actually improve the care that we provide patients. So this is a study where patients were randomized to get input on antibiotics from the stewardship program shown in gray here, the AMP, Antibiotic Management Program, or to get whatever the provider would normally prescribe. That's usual practice. And you can see if the stewardship program was involved with the antibiotic selection and management, you were almost 3 times more likely to get the right antibiotic. You were almost 2 times more likely to have a cure of your infection, and you were 80% less likely to experience a treatment failure. So based on all of this data, we have set a goal that every patient in hospitals in the United States should get an antibiotic only when one is needed. They should get the right antibiotic at the right dose for the right duration. Now, we know that there are some important differences in trying to improve antibiotic use in small and critical access hospitals than in types of hospitals. And that is something that we have certainly been educated about here at CDC by our colleagues in the critical access and small hospital community. And one of the things, of course, that's different is that the drugs you use are a little bit different. So this is a list of the top antibiotics that are prescribed in different bed sizes, so fewer than 25 beds, 26 to 50 beds, and greater than 50 beds. And you can see there are some really important differences, and they're the differences that you would expect, right? So in smaller hospitals, you all do tend to use a lot more of the agents that we would think would be directed at treating community onset infections. So ceftriaxone and fluoroquinolones are used much more commonly in hospitals with 25 or fewer beds than they are in hospitals with greater than 50 beds. So I think this definitely reflects, and it makes exact sense, it reflects that the patient populations that you're caring for and the type of infections that you are treating. We do have a document that we call the core elements of antibiotic stewardship programs, and these are the essential practices and procedures that we think should be in place and have been associated with highly effective antibiotic stewardship programs in a variety of different settings. So we first launched these for hospitals in 2014, and then for nursing homes in 2015, and then for outpatient settings in 2016. And we have been pleased to see that over time, the number of hospitals that have implemented antibiotic stewardship programs with all 7 of these core elements has risen pretty dramatically over time. So we first started assessing this nationally in 2014, and in 2014, about 41% of hospitals reported to us that they had a stewardship program with all 7 of the CDC core elements. And by 2017, you can see that had risen to 76% of all hospitals in the United States. So some really impressive gains. There is quite a bit of geographic variability, though, in the implementation of these core elements. And what you can see is that states that have tend to have more rural populations and a larger percentage of critical access hospitals do seem to have lower rates of implementation of the core elements. You can see, though, that Indiana is doing extremely well. You guys are at right about 90%, 89% of all of your hospitals implementing the core elements. So that's certainly very encouraging. And indeed, when we break this down by bed size and hospital type, we see exactly what I just showed you on the last slide. So critical access hospitals and hospitals fewer than 60 beds tend to have lower rates of implementation of antibiotic stewardship programs based on these CDC core elements compared to larger hospitals. And you know, that's not surprising when we think about, and we talk to experts in critical access hospitals and in these smaller hospitals, and they say, you know, there are a number of different challenges that we have to address and some barriers to antibiotic stewardship programs in critical access hospitals. For example, they tell us that, you know, there's historically been perhaps a misperception that antibiotic overuse and the problems of resistance in C. diff are limited to larger hospitals, and we don't see that in critical access hospitals. That's not true, but that's maybe been a misperception. They point out that there's been limited access to infectious disease clinicians, so many critical access hospitals don't have an infectious disease practitioner on site or affiliated with that hospital. And in many places, it's, you know, been these infectious disease practitioners who've been champions for the stewardship efforts. So in critical access hospitals, we maybe need different champions. And they point out, and very rightly so, that past recommendations for stewardship program really have ignored the realities of critical access hospitals. You know, they point to guidelines that have been put forward in the past that say, you know, your first step in having a stewardship program is to assemble a team that's led by an ID clinician and an infectious disease trained pharmacist. Well, if you have neither one of those, then those guidelines can't be implemented in your hospital. But we know that it can be done. So there are a number of hospitals. In the last survey, there were over 800 critical access hospitals that reported data to CDC, and over 200 of these had found ways to implement all 7 of the CDC core elements. So critical access hospitals definitely can implement the CDC core elements. And of course, as you all know, the Medicare beneficiary Quality Improvement Program, MBQIP, is seeking to increase that number, and they have made implementation of the CDC core elements for antibiotic stewardship a required component of MBQIP for 2018 to 2021. But we obviously want to work to support all of you in your efforts to implement stewardship programs. And one of the things we wanted to address was trying to overcome some of these historic barriers. So we began discussions with these hospitals that had implemented the core elements to find out how they were able to do that. What were the things that they had been able to do that made them successful? What we wanted to get were suggestions from critical access hospitals for critical access hospitals. And I use the term critical access hospitals, but we of course did have some folks who were in hospitals that were by definition not critical access hospitals, but were in that small hospital category, so in the 30 bed size category. We collaborated with a number of different experts. We had experts from all of the states that are highlighted in green below. We talked to experts in all of these different states. So you can see we really did get a very broad diversity of inputs from experts in small and critical access hospitals. And then we sought to work collaboratively with a number of different partner organizations, including the Federal Office of Rural Health Policy, the American Hospital Association, the Pew Charitable Trust. We brought all of these groups together with the experts in small and critical access hospitals to develop this document, Implementation of Antibiotic Stewardship, Core Elements at Small and Critical Access Hospitals. And so this is a document that is designed specifically to help small and critical access hospitals implement the core elements for antibiotic stewardship. We know that the MBQIP program is working to try and help promote this. Most critical access hospitals, essentially all of them, do participate in the MBQIP program. And as I mentioned, implementation of the core elements is now a required component of MBQIP. Let me walk you through very briefly what these core elements are and some of these suggestions that came from our discussions with the critical access hospitals of how you might implement these core elements in the small and critical access settings. So the first core element is leadership commitment and accountability. So some of the things that the critical access hospital experts told us is that in a smaller or critical access hospital, it can be really helpful to designate a physician in the C-suite or an individual that reports directly to the C-suite to be that leader of the stewardship program. And in many cases, they said, this is likely not to be an infectious disease practitioner. This is much more likely to be a hospitalist, for example. They said, it's really important to integrate stewardship into all of the different quality improvement efforts. One of the critical access experts told us, look, I'm the physician lead, but I'm also doing all of the sepsis work. I'm doing all of our pneumonia work. So for me, it made sense to just integrate all of these different quality improvement efforts together, and it makes all of our individual efforts go a lot further. In the critical access setting, one of the things that was emphasized to us was really working to engage the board. Because they said, in the critical access setting, this may be different for larger hospitals, but our board is really engaged in what we do and very, very supportive. And several of these critical access hospitals said, we actually asked our board and our C-suite to issue a formal statement on the importance of antibiotic stewardship. And that was helpful not just in educating our practitioner community, but also educating the community, the patient community around our critical access hospitals that we serve. Again, they said that one thing that could be helpful is enrolling in multi-hospital collaboratives. So we know that there are a number of states that have ongoing efforts for quality improvement for antibiotic use. There is work going on through the Hospital Improvement and Innovation Networks, the HINs. They said, oftentimes it's really helpful for us to join those collaboratives because it allows us to tap into expertise that we might not otherwise have. Or we could partner with a larger hospital or an academic center that is in our referral network to get stewardship expertise and collaboratives. Several of the critical access hospitals mentioned that their leadership was funding remote consultation or telemedicine with experts in stewardship. There are a number of what are called these tele-stewardship programs that are in existence in a number of different places where they can provide you remote support, and the leadership can provide funding for that. And they said, one of the things that another hospital said is that we actually now put stewardship requirements into the contractual responsibilities of our pharmacists when we contract those services. Drug expertise is core element number 3, and again here critical access hospitals really had some creative ways that they had addressed this. They had appointed a pharmacist leader. Many of them said that we oftentimes do have a pharmacist person who is either full or part-time at our facilities, and we've made them our stewardship lead because they're so involved in drug dispensing and administration. A physician leader to provide support to that program was also oftentimes mentioned to be very, very helpful in the critical access setting. And then offering training in stewardship to help develop some of that local expertise. There are a number of online and in-person training courses, and our critical access colleagues said, those have been very helpful to us in developing some local expertise. And then, of course, also what we've already talked about, the access to telemedicine or off-site support that may be very helpful. Action is the fourth core element, and this is really taking concrete steps to improve antibiotic prescribing. And in critical access hospitals, what was really emphasized for us here is that there are 3 conditions that really comprise the overwhelming majority of all antibiotic use. And frankly, this is true in all hospitals. If you take community-acquired pneumonia, urinary tract infections, and skin and soft tissue infections, those 3 infections alone comprise about 73% of all antibiotic use in all U.S. hospitals, and that percentage is even higher in smaller and critical access hospitals. And the good news is there are a number of different potential improvement actions that are specific to these 3 conditions, and that core elements document that we've developed highlights some really concrete interventions that you can implement for pneumonia, urinary tract infections, and skin and soft tissue infections. Tracking is our 5th core element, and there were, again, a number of great examples from our colleagues in critical access hospitals on how they have found ways to track and monitor antibiotic use and resistance. Many critical access hospitals are now reporting their data into the CDC, into the National Healthcare Safety Network Antibiotic Use and Resistance module. The beauty of that is that it allows you to get risk-adjusted benchmarks of your antibiotic use, so you can actually compare what your antibiotic use looks like to hospitals that are similar to yours, and lots of critical access hospitals have found that to be useful and are now reporting data into this. Critical access hospitals also told us, hey, we're monitoring adherence to our treatment recommendations. We have specific treatment recommendations in our hospital, and we are monitoring adherence to those. We monitor how often antibiotics are changed or stopped after 2 or 3 days. This is this idea of an antibiotic timeout, and we assess how often that happens. Some critical access hospitals told us that they, regularly do medication use evaluations to see if there are ways to improve prescribing. And what our critical access hospital colleagues told us is that we oftentimes focus our evaluation on drugs that we don't think we should use very much of, things like piperacillin-tazobactam or carbapenem. So we focus our efforts there to see if there are opportunities to improve. And a couple of critical access hospitals told us, this is something we oftentimes do have pharmacy students that are rotating through our critical access hospitals, and this is a great project for our pharmacy students. So when they come through, we oftentimes have them help us with these use evaluations. And finally, one of the other things that critical access hospitals told us is they oftentimes monitor how often patients are converted from intravenous to oral therapy. Reporting data back to providers is another core element, and they said, critical access hospitals have found a number of different ways to do this. They prepare regular reports on their antibiotic use, and they take them to kind of standing meetings, either with the Pharmacy and Therapeutics Committee, the Patient Safety Committee, quality committees, medical staff leadership. One of the things that critical access told us is that the one advantage that we have is that our small size really allows us to connect with all of our providers. We know each other. So it's easier for us to kind of get this data in front of each other and share this data. One of the things they told us is that we oftentimes are able to do some provider-specific reports, and this again is a strength that is unique to smaller and critical access hospitals, where if there are a small number of providers, they actually are able to provide data to individual providers on their antibiotic use. And then they said, we really do have good engagement with our newsletters and emails. People actually read these things in the critical access setting, and we found that to be a really useful platform for getting this information out to folks. And finally, education. Lots of, again, really good examples of the types of things that critical access hospitals are doing to educate their provider community on antibiotic use and resistance. They said we've integrated these updates into our communications tools, our website, our newsletters. We're providing in-person or web-based education to our providers, and that's either done kind of one-on-one when people are making rounds or done during group conferences. We incorporate stewardship into credentialing and re-credentialing at our institution. Several critical access hospitals mentioned how important this was, given how many providers they have who are doing locums assignments, and so making this part of the credentialing was very helpful for them. Several of our critical access hospitals told us that they had very active patient family advisory committees, and those committees have been really engaged in stewardship efforts. They told us that developing stories on how patients' lives are affected by the complications of antibiotic use, like Clostridium difficile, had also been very, very helpful. And then they said, patients really love this information. And so we've worked to develop patient education materials. And there's a lot of those materials available on websites. We have some at CDC, and people have taken those and adapted them as they needed to. Some of the key lessons there, some of the tips that we've learned for ways to implement stewardship in critical access hospitals that may be different from other types of hospitals. One of the things that we've seen is bedside nurses taking a really active role in working to improve antibiotic use in critical access hospitals. Very different from other hospital settings, and that's been wonderful to see, where the nurses in these critical access hospitals said, we're the common thread through all of this care. We are the ones who are here all of the time, and so we can really play a role. We may be the first one to see a culture result that comes back, or know that we could switch or stop an antibiotic. And in fact, the CDC has been working with the American Nurses Association to really work to expand the role of bedside nurses in antibiotic stewardship, and I think the critical access hospital setting is a perfect place for us to emphasize that and find ways to grow that role. The other thing, and I've alluded to this, is that the strong relationships between staff members at critical access hospitals often makes your performance improvement efforts easier to implement and more successful. Critical access hospitals have told us that once we decide to do it, we're very likely to succeed because we really are in it together. We know each other, we work together, we live in the same community. We see each other not just at the hospital, but at the grocery store and when we're out and about town. So we really have a sense of collegiality that may not exist in larger hospitals. And the small number of staff does make it possible to provide some of that one-on-one education that is just not realistic if you have hundreds of providers. And the fact that, oftentimes it's the same group of people that's working on C. diff and stewardship and sepsis means that you can integrate all of these efforts to have a multifaceted improvement project. I wanted to close my talk by providing you, sharing with you some of the resources, and many of you may be very familiar with these, but you guys have a number of fantastic resources in Indiana dealing with antibiotic use and resistance and helping educate people. And many thanks to Tina Feaster, who shared all of these with me, and her email address is here. So if you need any information about these or about what's going on locally, please do contact Tina. You've got this great video. This is fantastic if you haven't seen this. This is Matt Hasselback talking about antibiotics. So, how often do we get to have a football star talk about antibiotic use? This is a really wonderful and a great way to engage, an audience, a demographic that we sometimes don't get to engage very much. So young people see this video. Of course, everybody knows who Matt Hasselbeck is, and so it's great to have him engaged in this effort. So this was a wonderful video. The public health message that's coming out from the sports teams and the Indiana Department of Health, working with the Colts to kind of highlight this, really raises the profile of this issue. They had a kids competition, which is great, showing ways to raise awareness about antibiotic use, resistance, the benefits of hand hygiene. So this was fantastic that Tina had shared with me here, and this is just a few more pictures from that. And then, really important highlights from the state health department, really demonstrating from the very top, the state health commissioner committing to using antibiotics responsibly. There are posters that you can print, and they're available on the state health department website, where you can show these commitment posters you can put in your offices and in your clinics to demonstrate to your patients that you are really working to improve the prescribing of antibiotics. Did a grand rounds on antibiotic use there. I think this may be even still available as a recorded format, but lots of things going on from the State Department of Health to try to raise awareness about antibiotic use and stewardship, and some really good materials locally tailored to Indiana on antibiotic stewardship. And you can see the link here, but resources for acute care hospitals, small and critical access hospitals, long-term care, and outpatients. So really good resources right there in Indiana. I'll just close, and we can open this up for your questions and your comments on things that we can do. Just by saying that I think antibiotic stewardship, I hope I've convinced you that it's every bit as important in critical access hospitals as it is in any other type of hospitals. I think that MB Quit Measure is going to help steer critical access hospitals in the right direction, really encourages them to work on improving stewardship. But our job is to make sure that you have the tools and resources you need in order to be successful. We are all here to serve you, the CDC, the Indiana Health Department, the Office of Rural Health. We want to help you. We want to know what you need from us in order to help your stewardship work be successful. So I do hope you will let us know, either reaching out, connecting with me, with Tina, with Becky. Let us know either right now or in the future what we can do to help you implement effective antibiotic stewardship programs in your small and critical access hospitals. And so with that, I'm going to end my remarks and turn it back over to Becky. Please do feel free to unmute your line if you'd like to ask a question, or please do submit questions in through the chat box, and we are happy to discuss any of your questions or comments. If you have ideas for things that you would like to see more of, or that you think we could do to help you, we would welcome that as well. So Becky, let me turn it back over to you and see if we have any questions that have come in through the chat box, or if we have anyone who wants to ask a question or make a comment. Thanks.
Great, thank you so much. I have had a few questions sent to me. The first one that came in was, can you expand on your comment on the role of telehealth in antibiotic stewardship?
Yeah, so this is something that's, I think, in early stages, but has been very, very helpful. There are a number of different groups that have these tele-stewardship programs that have been set up. I know the ones that I've seen are in places out west. There are some of these programs. So, if you have questions about whether or not this is available in Indiana, that's something that Tina Feaster might know, or it's something that, certainly Becky and Tina and I could look into to see if there are those types of resources that are available to hospitals in Indiana. But this is definitely a growing kind of a growing enterprise, and something that I think is going to be very, very useful to give people access to stewardship expertise who might not have it. And so we can certainly look into that for you to see if there are tele-stewardship resources that are available to you there.
Okay, great. The next question that came in were, Are there any additions or any changes to any of the standards that is up and coming that we need to be aware of?
I'm not sure which standards you're referring to. I don't know if you're referring to like CMS standards or conditions of participation. You may know that CMS did propose making antibiotic stewardship programs a requirement in the revised conditions of participation for critical access hospitals and all other acute care hospitals as well. Those conditions of participation are still in a proposed state. They've not been finalized. But the requirement is there in those proposed conditions of participation. And the Joint Commission has made antibiotic stewardship programs a requirement for all of the hospitals that it accredits nationally. So there are a number of either proposed or approved requirements through CMS and the Joint Commission, and then of course the requirement from the MB-QIP program.
Okay, I'll follow up and make sure that's the standard that they were referring to, and if it's any different, I'll email that to you and we can get a response back. But I bet you that covers the question. We have a question that was just chatted in. How are critical access hospitals collecting AU data? Can it be done without a specific software, the antibiotic use data?
Yes, thank you. So there are a couple of different ways to do it. You know, internally, most of the pharmacy vendor programs that you might have internally, whatever system you're using, should be able to help you track your own use internally. And so, you know, your pharmacist may already know how to do that, or may be able to talk to whoever provides your pharmacy tracking system. Most of them can provide some sort of a report in order to allow you to see your own antibiotic use. And, you know, depending on what system you use, it'll dictate what measure, but as long as you have the same measure over time, then that's useful to you internally. Any hospital can submit antibiotic use data to us at CDC into the National Healthcare Safety Network, into the antibiotic use option. There are a number of different ways to submit that data. Many different types of electronic health records now are allowing hospitals to submit. They will submit that data for you. So if you have specific questions about how to submit your data to the antibiotic use option, or if you're interested in exploring that further, there's a lot of information on our website. If you go to the National Healthcare Safety Network website, you can see the information on reporting antibiotic use data. You can also search for the NHSN antibiotic use option. And if you have any other questions about that, please do feel free to email me. Happy to connect you to folks, even connect you to folks in critical access hospitals who are submitting data, so you can discuss some of the various options that might be available to report that data into CDC's antibiotic use option.
Great, thank you. One last question that was emailed to me relates to a video that you have posted on the CDC website with patient tips. Is it acceptable to use that video in educating patients within the facility and in physician practices, such as to show the video in waiting areas?
Absolutely. What's ours is yours. Anything that's on our website is free and fair game for anyone to use. We encourage you to use that. We would love it if you would use it.
Great, great. I have another question that was just chatted in. How will the MB-QIP measures be reported via NHSN? And
right. So go ahead.
Go ahead.
Yes, so the MB-QIP measure will be reported into NHSN. So all critical access hospitals will need to enroll in NHSN. I think almost all critical access hospitals are, because there are some healthcare associated infection reporting requirements that you guys have to report into NHSN. And so the data that MBQuip will be using will be the data from the annual facility survey that all of the hospitals that are enrolled in NHSN have to fill out. So that survey is released each year in January, and you have the first quarter of each year to report on the status of your hospital for the previous year. So for example, in January of 2019, the survey will come out asking you about what was going on in your hospital in 2018. And so you will have from January to March of 2019 to complete the 2018 survey and provide that information. And then CDC will then give that information to the folks in the MBQuip program.
Correct. That's what I wanted to clarify. Thank you for doing that, that there's no separate submission that the MBQuip team here.
One submission. Good question. One submission. You report the information to us at CDC, and then we will then share it with MBQuip.
Correct. And I believe that is all the questions that we have for right now.
Great.
So,
fantastic.
Thank you so much for joining us today and sharing all of this great information. I think that the critical access hospitals will be able to take your presentation to their committees and almost use it as a checklist to make sure that they have some of those key interventions implemented related to the core elements. So we will be, today's session was recorded. We will be sending out the link to the recording so that you can share it with others in your hospital. I will also make sure to share the link to the State Department of Health Healthcare Associated Infection Resource Center, to that website that has all of those resources that are very specific to Indiana, and the toolkit referenced on today's call. So we'll be also, if you notice in chat, there's some additional websites that have been shared and some links. And Dr. Srinivasan has also published some great articles on this particular topic. So we'll send you links to that as well. So thank you all for joining today. I hope you found today beneficial. And again, thank you to Ali for her support from a technical perspective with Zoom, and to Dr. Srinivasan for sharing his wisdom, knowledge, and passion today. So have a wonderful day, everyone.